this is a case. First I'll brush through the anatomy and biomechanics of meniscus. All of you know. So meniscus tears can cause profound functional, biomechanical, and kinematic derangements within the knee joint, leading to accelerated degeneration of the articular cartilage. So just now, Shishir threw a very good light on about the preserving of meniscus. So here we are discussing about reconstruction of the meniscus. The menisci are crescent-shaped fibrocartilaginous structures with wedge-like cross-sections that function to deepen the tibial plateau, transmit load through the joint, provide shock absorption, and increase knee joint stability. As a result, any deficiency of the meniscus can lead to accelerated degenerative changes, and resection of as little as 10% of the meniscus can contribute to development of chondral lesions. So lateral meniscus measures about, since I am talking about lateral meniscus reconstruction, we'll focus on lateral meniscus. It measures about approximately 35.7 millimeter in length. The lateral meniscus width is more posterior when compared to anteriorly. And the thickness wise, it is thicker more posteriorly when compared to anteriorly. And study shows lateral meniscus covers up to 59% of the lateral meniscus, lateral tibial plateau. So lateral meniscus are attached to the tibial plateau through their anterior and posterior roots and are stabilized by the popliteal meniscal fascicles, posterior superior anti-inferior, transverse ligament, meniscotibial ligaments, meniscofibullar ligaments, and meniscofemoral ligaments. And the uniqueness of these attachments is it will allow the lateral meniscus to be more flexible and mobile. The role of meniscus roots, very important. It helps the meniscus to preserve the biomechanical ability to convert axial loads to hoop stress and prevent extrusion and decrease the load placed on the articular cartilage. So its effects, the avulsed meniscus roots lead to increased contact pressures on the articular cartilage that is comparable to the forces of a knee after a total meniscectomy. Clinically, this progress to a rapid progression of osteoarthritis. So blood supply, as all of us know, meniscus has got deficient blood supply, but it gets 25% in the periphery through the middle geniculate and inferior lateral geniculate, particularly for the lateral meniscus. The biomechanics, the load distribution properties of the meniscus allow for greater contact area and decreased contact pressures within the tibiofemoral joint. This is particularly important in the lateral compartment because 70% of load is transmitted to the lateral meniscus when compared to 50% of the medial meniscus. So we'll discuss about our case. It will almost like a real life surgery. Is a male patient, 32 years, moderately active, well built, not obese, and had ACL reconstruction long ago with a near total meniscectomy in 2006. So patient presented to us with on and off pains, and which is quite chronic now, almost 1 to 2 years of time, and he did not had any instability symptoms. His ACL was performing well. X-ray and scanogram were normal. So this is MRI which shows his previous ACL reconstruction status. And here we can notice there is a absence of posterior horn and body, and there is no root as well. So there is only anterior horn present, no mid body and no posterior root. This is a coronal section showing there is actually no meniscus in the mid body and posterior root. Anterior horn is partially intact. So what are the treatment options? My treatment options were to do a tendon autograft, semitendinosus or peroneus longus, meniscus allograft or a scaffolds. Scaffolds are not available with us. You can have an option of meniscus allograft, but the problem is it is expensive and there are certain risks involved. And I discussed all these things with the patient. Patient wanted to go with a tendon autograft. So this is the plan what we made. There are a lot of papers on semitendinosus, and I chose peroneus longus for the lateral meniscus because it is thicker and it is more consistent in diameter when compared to semitendinosus. For the lateral meniscus is more thicker when compared to medial meniscus. And also patient did not agree for allograft. The advantages, as I described, elaborated earlier, easily available, no immunogenic reactions, no risk of disease transmission, and reasonably economical when compared to allograft, and technically easier as well. So I referred few papers. So here all the papers are supportive. All the early and midterm studies supportive of transplant survives and adapts to a shape and capabilities to the original meniscus. And yes, it also performs well for all the biomechanics. It equivalent to the meniscus. And I chose this particular paper and then went ahead with this surgery. The surgical technique we did in supine position, tourniquet control, the standard anteromedial and lateral portals. I harvested the perennis longus graft and prepared it, doubled it to 15 centimeter, doubled it, obtained length of 15 centimeters, and 6.5 to 7.5 millimeter was the diameter. So 6.5 millimeter, I used it for anterior, as anterior horn is less thicker when compared to posterior horn. So this was whip stitched and wrapped with size 0, and this was soaked in vancomycin. Traction sutures were put, and anterior and posterior bony tunnels were prepared, and graft was passed through the anterolateral portal. At first, graft was dunked into the posterior bone tunnel, followed by the anterior bone tunnel. So graft was properly aligned with the help of bird beak and suture retriever. Mid body of the graft was first fixed with inside-out sutures, followed by fixing the posterior horn with multiple all-inside suture anchors, and anterior horn was fixed with outside-in suture techniques. Fixations were continued until the stable fixation achieved, and finally, I fixed the posterior root and anterior root with suture buttons. Can I have a voice? Is it possible? There. This video has a voice. You don't have a jack. Ilwa?
Dharampal, you yourself can comment.
Okay, sir. I'll make. So this is the graph. So this is the graph which I have prepared. This is the perennis longus. So the point where I'm marking is for the posterior root, P is for posterior, A is for the anterior root, and on that just below my hand I marked L. That comes towards the lateral. So these three are traction sutures. And first I'm giving the outside picture. I'm passing the graft. So we'll go to the. Can I continue?
Please.
Okay. So this is diagnostic arthroscopy. Absent posterior horn and body of the meniscus, lateral meniscus. ACL graft was intact. So I did a good debridement and freshening until I saw some blood. So here we can see there was a residual anterior horn, and I removed that segment completely. Now I'm drilling the posterior transosseous tunnel in the anatomical area. It is size to size match, 7.5 millimeter. And this is anterior transosseous tunnel. So I retrieved the sutures, ethibond for the anterior, and I used ethylon for the posterior. That's actually suture retrieval. Check that there is no suture bridge in between. Now I'm going to pass the graft, the posterior one first. followed by the anterior. So I brought a bird beak from outside to pull the tension sutures, which I had put 3 numbers in between. With the help of tension sutures and these instruments, I'm positioning the graft properly into the respective place. The first suture what I'm going to use is the inside out meniscal suture in the mid body. And followed by that for the posterior horn and the body for multiple fast fix sutures I used. Quite a lot of sutures were required to stabilize the graft. I'm checking whether all are stable. Wherever I felt it is little loose, I continue to use the fast fixes. I made company people happy on that day. The point is fix the graft as much stable as possible. So this is my assessment of the graft stability. I had to cut the tension suture separately. That was just it was just to assist me to put the graft inside. So this is the post-operative X-ray. So the lateral joint line is maintained, and there is no arthritic changes because of his previous near total meniscectomy. So my post-operative protocol is 0 to 6 weeks. First 0 to 6 weeks is non-weight bearing walking with knee brace and walker, assisted range of movement exercises up to 90 degrees. I even started him on CPM, static quad exercise and SLR exercises. And for next 6 to 12 weeks, now he's only 2 months now since his surgery. He's in his second month. He is toe touch weight bearing and progression of knee bending to 120 degrees and strengthening exercises for the quadriceps. So my next protocol will be after 3 months, after 6 months to be precise. I would like to do a repeat MRI, and at 1 year again post-operative do repeat MRI. Thank you for your attention.
Thank you.